Welcome to session 5 of Women's Economic Empowerment Annual Conference. I am Abby Fapahunda. It's a pleasure and honor to be the moderator for the health of women as an economic value, impact of COVID-19, challenges and opportunities for response and resilience. I would like to present the keynote speaker, Dr. Patricia Odero of Duke Global Innovation Center. Over to you, Dr. Odero.
Thank you so much, Abby. Good afternoon, good morning, and good evening, everyone. Greetings from Nairobi, Kenya. I'm Dr. Patricia Odero, the Regional Director at Duke University's Global Health Innovation Center. And today I have the honor and the pleasure to share a few reflections on how women's health has economic value, drawing on my work across the African continent, as well as my lived experience primarily on the continent. Just a bit about me, I'm a medical doctor. I practiced as a general practitioner briefly before pivoting to public policy and health system strengthening, with a focus on women's health, and now focus my work on how healthcare innovations can increase access to quality of care. So did you know that 70% of the global health workforce are women? And once you add social care workers, that number actually increases to 90%. And a recent study actually showed that 70% of COVID-19 infections have been in healthcare workers. Whilst this was a study done in high-income countries, I believe that the story is the same in low and middle income countries. But of course, that is an untold story. And so how, women before the pandemic, women and girls actually faced a myriad of challenges that limited their social empowerment and economic participation. In fact, it may often feel that odds are not in favor of women when you think about their health. So for example, in Africa, women are more likely to die from communicable diseases and maternal health conditions. And 1 in 4 deaths among African women are from non-communicable diseases. Whilst another study from the World Health Organization showed that 20% of women in low and middle income countries actually have postnatal depression. And now we also face, unexplored causes of illness such as aging and disability. And so, in addition, care pathways are often not optimized for the needs of women at the different stages of their lives, with them facing financial and social barriers, whether it's a rural woman needing to travel long distances to access critical services, or a teenage girl in an urban informal settlement, unable to access critical sexual and reproductive health, education, and services. And then, of course, the quality of care that women face, is disproportionately poor, as evidenced by the high rates of maternal death. So what happened in 2020 once the pandemic, emerged? So for a lot of healthcare workers in low and middle income countries, it was really a crisis. You basically have this unknown vector, this unknown virus. You're faced with patients who are coming in. You have a lack of personal protective equipment and other supply chain failure. So for example, in Kenya, there were numerous strikes by healthcare workers about the quantity and the quality of personal protective equipment. And over time, just this fight against, and seemingly insurmountable disease led to, chronic fatigue, what has been dubbed as the COVID-19 effect, which has been described as a unique and complex form of trauma with potentially devastating consequences, both for short-term and long-term for individual nurses and healthcare workers, as well as the systems that they work in. I remember, as I said, I'm a medical practitioner by training. So some of my closest and dearest friends are actually frontline health workers. And I remember, for example, holding space for a colleague who had just discovered that she was pregnant with a long-awaited baby, but she was a frontline healthcare worker. Mm-hmm. And she was very concerned about the lack of personal. Quite a few of her colleagues were, sick or dying of COVID-19, and just her limited options because there are limited ICU and HDU facilities in Kenya where I live. So as a result, over time, this has had, an adverse effect on mental health, of healthcare workers. So a recent survey across 13 African countries actually showed that 1 in 5 nurses reported daily depression symptoms. And essentially, apart from now the healthcare work, the effect of the pandemic on healthcare workers, there's also been a broader effect on women and girls. So with limited options available in most low and middle income countries across Africa and Asia, political leaders resorted to lockdowns and restriction of movements. And so the economic effect was, wide and far-reaching. So in 2021, the International Labour Organization's figures showed a significant contraction in the informal sector, which employs quite a large number of women in Africa. And the previous panel, of course, talked about gender-based violence and the ongoing pandemic that is gender-based violence as a result, which has increased as a result of COVID-19. And across the world, including in low and middle income countries, women have continued to bear the burden of increased caregiving and unpaid domestic labor, which has then resulted in quite a number of women dropping out of the workforce. So because as part of WEI, we believe that women's health has economic value, we need to systematically build back better if we are to honor the contribution made by women in the health sector. And so what does creating a resilient health sector look like? What does building back better look like? So here are about maybe a couple of perspectives from, and I'm sure the panel will expound on this. So a key part of building back better is ensuring equitable access to vaccines and COVID-19 management, diagnostic devices, as well as medication to low and middle income countries, to women and girls there, as well as to healthcare workers, frontline healthcare workers. Then, of course, another way of building back better is to encourage innovations that optimize how healthcare can be accessed, including the self-care movement. How do you ensure that critical services, including family planning, are delivered in ways that put women at the center of healthcare decisions? And those care pathways actually are optimized for how women live, where they work, and where they are to be found. And then a third area is around universal health coverage and social protection. I believe that countries need to strengthen universal healthcare and other social safety nets to reduce the financial burdens and challenges and barriers that women and girls face as they seek to access quality healthcare. A fourth way of building back better is being able to implement policy changes that recognize the value of unpaid and underpaid labor in the health sector, especially around community health volunteers. And I'm sure the panel will delve deeper into that. And then lastly, another way we can build back better and create a more resilient healthcare system is by being able to make sure that mental health interventions are accessible to women and girls, including leveraging innovations such as digital counseling. And so just being able to make sure that the health system is really optimized to ensure that women and girls are able to access care as they need it, where they need it, and when they need it. And so who needs to do what? So I'll provide just a couple of thoughts because our panel has such rich wisdom. I'm sure we will have, a collection of recommendations. 2 areas based on our work at Duke. So at the end of 2020, we launched a small-scale project called the Launch and Scale Speedometer, which really was looking at data on COVID-19 vaccine advance purchases by high-income countries. And what that data showed is that essentially countries had bought, in advance, vaccines that were 5 to 10x the amount that they needed, therefore locking out low and middle income countries. And so why do I share this case study? Because that small piece of research then caught global media attention and formed the narrative around vaccine inequity and has led to subsequent policy change. Whilst this, of course, is ongoing and more could be done, I think just that research was able to really just bring this key issue to the attention of global media. And so a lot more needs to be done around academia and research to bring the evidence around, the of women in the health, women's work in the health sector and the contribution that is that they provide, so that then we create a narrative that's more broadly recognized and something that can be picked up. And I believe the pandemic has provided, a wonderful context and background for this. And then secondly, collectives such as WEI need to amplify this evidence and continue to grow the coalition of the willing to make sure that when action is needed, then there's actors that are, primed and ready to bring about the required policy and financing reforms that recognize the value of, women's contribution to the health sector. And so with that, I will say thank you for listening and looking forward to a wonderful and engaging discussion with my fellow panelists. Back to you, Abby.
Oh, thank you, Dr. Odero. You really showed us that the pandemic has really increased the health and well-being and creates a vulnerability for women and girls. And it's even, especially now with the pandemic, it's really more even highlighted. And then you covered a lot in your talk, talking about barriers that women and girls have to go through, and even that access to vaccine and medication and the need for universal healthcare. And you talked about the policy change and the people that need to be part of this research. Institutions has to be, the health department has to be, and to really optimize that health system and to be affordable and reachable for girls and women. Thank you so much. I hope you'll be able to continue to join us in the panel discussion. And for now, without further ado, I would like to present our panel speaker. I will start with Dr. Gogoi. Can you please introduce yourself, and we go from there.
Hello, everyone. This is Dr. Patricia Gogoi. I am the executive director of an Indian nonprofit called Center for Catalyzing Change. And we've been working for the last 35 years to make the lives of women and girls better. Thank you.
Thank you. Dr. Aya, can you please introduce yourself? Thank you.
Yeah, good afternoon, good morning, and good evening to all of you. I'm Dr. Sandhya Iyer. I'm an associate professor and chairperson at the Center for Public Policy, Habitat and Human Development at the School of Development Studies, Tata Institute of Social Sciences, which is a deemed university in India, Mumbai. Thank you.
Thank you. Ms. Ngogo, can you please introduce yourself?
Yeah, sure. Hi, good evening, good afternoon, good morning to everyone. It's great to be here. My name is Belinda Ngongo, and I work for the private sector, mainly biotech industry. And I'm also the founder of the Pan-African Women in Health, which is a network that supports women that are working in the health space on the African continent.
Thank you. Let's start with the first round of questions. Dr. Gogoi, I would like to point this question to you. Can you tell us about the work of your organization in supporting women and girls, particularly pertaining to health and economic empowerment?
Thank you, Abby. And I just want to kind of begin by reiterating what our keynote speaker stated about COVID-19 really unearthing some grave inequalities in our societies. And it brought to light the unique burdens which women carry, not just in my country, but all over the world. And I think in a way, COVID-19 and its impact on women and girls have really made apparent the kind of the connection between gender inequalities and access to health or access to livelihood. Because we know that gender inequalities have a huge impact on women's ability to access education, access healthcare, and other services. Now, often we think that there is only a physical lack of access, but we know that even if there is physical access, poverty, inequality, prevailing norms in various forms, in various cultures, all of it hinder women's and girls' access to what is needed the most. In India, my organization, Center for Catalyzing Change, we work across multiple sectors which impact the life of women and girls. But I will today direct my comments only to what we have been doing, trying to respond to the challenges that COVID brought. During the pandemic, and again, like a keynote speaker said, it was not just the pandemic, but the subsequent lockdowns, the unlock phases, the uncertainty, all of it really created and is creating havoc in the lives of people. But in order to get the information about what is happening on the ground, we conducted multiple surveys, and it confirmed our worst suspicions that women and girls had been disproportionately affected by the larger consequences of the pandemic. And what we do is really try and look at what we can do about this loss of livelihoods, about limited or no access to sexual and reproductive health services, about lost educational opportunities, widespread experience of gender-based violence, and I think the profound toll that COVID has taken on mental health. And in order to support women and girls, what we have been doing is really focusing on how do we ensure that sexual and reproductive health services, family planning services, childbirth, abortion services, newborn care, how can these services be maintained as essential even when disasters strike? And there are things that people can do at the local level, at the systems level, and at the policy level to ensure that some of these core services are not impacted, due to shocks like COVID. And I think what we're doing right now, even in today's panel, I think what we're looking at is how do we make recommendations which countries can learn to stop the disruption of essential services. Health and education for women and girls is really, really closely related. So I also want to talk a bit about, what we have been doing around education. I think all of you know that COVID disrupted education. Schools stayed closed for almost 2 years. And closure of school is really led to loss of learning. And many girls that we work with, that we work for, they do not own digital devices. The family do not own digital devices. They have very basic digital literacy. So the online classes were literally of no use to them. And today, when the schools are reopening, even if the girls get back to school, we know that they will not be able to cope with the academic pressure. And that's the reason why we are working with girls and families, number one, to ensure that girls come back to school, and also taking initiative like, setting up a remedial coaching center for girls so that, they can get some sort of a tuition to catch up on the loss of learning. I think many things that we have been doing. Lockdown again led to disruption of supplies, and girls from marginalized families who actually get their the sanitary pads which are distributed in schools. So schools closed and they couldn't access sanitary pads. So what an initiative that we are doing is we have set up these pad banks which are run by girls in the communities, and through these collectives and the pad banks, the girls are not only promoting menstrual hygiene, but they're also learning business skills. They're also learning, life skills, how to co-own and run a business. So that's, the last thing that I want to really talk about also is that, I think we don't often talk about the fact that when crises strike, at times like this, we see a resurgence of, negative traditional and social norms. COVID has led to job losses, families have sunk into poverty, and this is leading to increase in child marriages. A family that we spoke to said, I want to get my girl married off because the lockdown says that I can't have more than 50 guests in my wedding and the wedding is going to be cheap. So in order to curb early marriages, we work with systems and communities to prevent child marriages. And of course, digital divide, I hope somebody in the panel is going to talk about, life has gone digital after COVID, but we know that in countries like ours, there is a huge digital divide. So how are we going to help girls to kind of, really kind of get out of this non-digital world, learn digital literacy, and learn how to use the 21st century skills to make their lives better. And I think the last thing that I want to say is, I think it's really, really important that we generate evidence and amplify voices of women and girls so that, women and girls are placed at the center as we plan to rebuild and recover. Thank you.
Thank you, Dr. Gogoi. That's really important to see what the obvious and the not very obvious of the challenges that girls and women are going through globally. My next question will be for Dr. Iyer. Dr. Iyer, your recent publication on missing women, you examine gender inequality across the array of socio-economic indicators. You noted that unequal access to healthcare, differential access to nutrition, comparative neglect of female children, sex-selective abortion of female fetuses contribute to the wider phenomena of missing women. Can you explain the concept of missing women and what drives the inequalities they face?
Yeah, thank you so much. And I think let me just tell a few little things about the kind of work that has been drawing my attention in the last 10 to 17 years of my work. Been doing a lot of policy evaluations and primary data analysis, not only in India, but in a range of South Asian countries. And most of my work kind of draws a lot on this empirical work of mine. What we find is that many a times when we discuss gender equality, we seem to be only trying to see whether women are reaching as par with what men are achieving. And we constantly seem to be comparing them on unequal platforms. And what we find is that in our endeavor to talk about gender equality, we are forgetting the historical inequities where women have been struggling to catch up with. And as rightly pointed by the eminent speakers right now, is that COVID-19 pandemic has exactly exacerbated those inequalities, that women really do not have equal access to public spaces, do not have equal access to resources, do not have access to freedoms of choice. In fact, in one of the dipstick studies that we completed in India, we found that women didn't even have access to hand sanitizers during COVID-19. They would give it away to boys, they would give it to men, saying that you're going to the public space to get vegetables, we will stay at home. So even those little things that COVID-19 was supposed to be seen as an important constituent to hygiene was part of a gender relation at the household level. So it is against this backdrop that I further deepened, in fact, my work. And I draw a lot on what Amartya Sen has spoken about is the presence of missing women. So what is missing women? Is it just about getting into sex ratio estimations to see how many females are there per 1,000 males? It does not really take us that far because that gives us only the absolute movement that is going on, maybe due to certain reasons. But missing women is a concept which goes far beyond that and starts talking about the process where gender-based discrimination biases within the society and within the larger, you can say, ecosystem keeps perpetuating the vulnerabilities of women. And the basic argument which we need to understand is when we talk again about the presence of women in society, women in development, in the economic process, we seem to be again placing them only as an instrumental entity within the larger measurement. We see them as productive agents, we see them as human capital. But do we really see the kind of unfreedoms that they're constantly facing and the kind of ascribed status that they are supposed to face? In fact, what came out in the number of you can say rapid assessment studies that have been generated in recent times is that women were further pushed back. If they were not frontline workers, they didn't have access to labor market opportunities. As already pointed out, there was a disproportionate distribution of care work on women because of the very dialect of what COVID-19 introduced, that we need to look after care, we need to be doing home-based isolation, etc., etc. The moment it was home-based, it meant women did much more. So you find exclusion, marginalization being embedded within the larger narrative. And when you really look at how this transpires, we find that even the understanding of social cohesion looks at it as in a very gender neutral sense. We feel social cohesion is only across caste, class, religion, and some sort of other denominators. But where are women? If women are not present in our debate on social cohesion, how are we going to achieve an equal society? So that's the point where I really place my discussion. And interestingly, even in the human capital narrative, you find women only seen as being productive agents. Whereas in the health analysis, if you look at the kind of work that's going on, why women are losing out in terms of access to healthcare, as rightly being pointed out, our focus is only on reproductive child health and maternal health. We do not see them having access to public health systems, nutritional facilities, access to water. So the entire story of health seems to be again narrowly seen in a very instrumentalist sense. In fact, the recent NFHS 5 results, which were released just last week in India, She said that it's after 30 years that suddenly we find sex ratios improving and we seem to be catching up in absoluteness in terms of population. But at the same time, you find a maternal health access issues, domestic violence issues, access to basic amenities is abysmally poor. It's still at around 47 to 48%, which means close to 52% women still do not have access to treatment in most cases. Therefore, the central point of my discussion in my recent works that I'm working on, particularly when it comes to SDG analysis, we need to understand two things. The recovery of COVID-19 and the last decade of SDGs cannot be seen in isolation. We need to see how are we planning the recovery path. Are we going to be seeing this in an isolated pattern where we try to only talk about gender-based policies or women's policies being introduced partially? Or are we going to be mainstreaming within the larger Agenda 2030 debate which is going on? The middle income countries are giving a very important story here. You find Bangladesh, for instance, providing social protection programs for most women. So there's near universal coverage of social protection, but the universal health coverage in most countries still is only at a rate of 10 to 20%. Women do not have access to health care. So there is a dichotomy over there. There is a discussion of women's labor force participation. We assume every woman is in labor force. But if you look at the data sets that ILO has just released, you find a declining rate of women's participation. So what happens to women who are not in the labor force? What happens to people who are disabled? What happens to women who are not part of any productive activity? Do we have any idea about what are we doing to them? So in my research that I'm finishing about the 74 middle income countries, my central argument is that we may focus on reduction of total fertilities. We may strengthen the RCH frameworks across, but we certainly do not have women in the center of discussing within the larger development policy narrative that's going on. And I think COVID-19 pandemic has further narrowed our understanding. We seem to be only looking at clinical solutions to a substantive problem. I can elaborate as we go on from here. Thank you.
Oh, thank you so much, Dr. Aya. You really covered a lot. And the bottom line is, it seems as if women have to tell their own stories. And women has to be part of research and collecting information, because if we don't tell our stories and we are not part of, being able to tell those stories, nothing will be known and nothing will be done. So thank you. That you covered a lot, and thank you. But let me move to Ms. Ngongo. My question for you is, can you share your perspective on women's health as an economic value, drawing on your experience in the pharmaceutical industry? And what are the challenges faced by women and girls?
Thank you. Thank you so much. And I just want to highlight my experience has really been in pharma and also biotech, which is very different industry, and medtech industry. But I think that, they are all kind of linked because it's really representing the private, what we call industry or private sector. And I think what I'll say is, in the private sector, you kind of have two arms. You have the internal work that is done by the company, and then the external work. And let me start by internally. And internally, I'm really here focusing on women that work for companies. And just to second what Dr. Odero highlighted at the beginning, we lost a lot of women during COVID. A lot of women left the workforce because of many reasons. And some of them to highlight is they felt that they had the workload increased. And a lot of them, for example, it was when you think of companies, many companies told employees to stay at home, and people actually thought, oh my God, it's great staying at home, working from home. But I think for many women, it's actually became a burden. And I mean, I lived in South Africa until recently. I just moved to the UK, but in South Africa, I saw a lot of young colleagues that maybe lived with their parents. And they just did not have a conductive environment to work. Either there was no office, there was no, they didn't have proper internet. So I think all these have contributed to kind of the health of women internally. But I think corporations or private sector has been doing a great job supporting women, establishing for things like mental health programs. They've been establishing, for example, even cervical cancer screening programs. They've been looking at, now I see a lot of companies now even looking at women that are going through menopause. They're giving them some time off when they are going through menopause. So they've done a lot of that. And I think all of that is really to create an equal environment where traditionally a lot of the people in leadership positions were male or are still male. And so they're trying to get more women at leadership positions, and all these interventions have been implemented, to support that. And when I look at the external factors or some of the external work that companies do, is they support initiatives, to foster women's health, and working with NGOs, with government, with all the multilateral, what they've been doing is, for example, some of my work previously was looking at cervical cancer screening in underserved population in certain African countries. And I think for me, those are some of the contribution that the industry is also doing. And they're also trying to also build the healthcare workforce by promoting STEM programs, or by even providing bursaries to students to enter their companies at a later stage. And I believe that these initiatives will have to be strengthened with COVID, because I think a lot has been lost, especially when it comes to women. And I believe that in a really public-private partnerships, to drive all of this. Yeah, let me pause here. Thanks.
Thank you, Ms. Ngogo. You covered a lot of very important issues. And a typical example is a lot of women had to stay home to do work, like men as well, but they have their children there. And at the end of the day, the man and the woman are in the same space. The children has to be taken care by the women, and their own jobs gets really, suffer for that. And another thing is, for most people, it depends on what your socioeconomic status is. You have a small house. Everybody is in the same room. The children and the mom and the dad are in the same room. You just can't work. It's not a conducive way. And that's extra stress on family, and especially women, with the extra thing they have to do on top. So you covered a lot. Thank you. If anybody, any of our participants have any question, can you please put it on chat? So I'm not sure if there's anything on chat yet. But let's go and move forward. I would like to go to Dr. Odero. I'd just like to ask a question regarding work being done, the kind of work you do in the clinical work, and I assume you're doing some research work as well. Do you think, how do we encourage more women, more women researchers or girls begin to be interested in research to be able to do more of this work? Because at the end of the day, it's the women and the girls that will be able to tell the stories, and then be able to educate the world about what we go through, about challenges. So how do you think that can be enhanced to encourage girls and then to be women who will be researchers and be clinicians, to do a better advocate, to be better advocate for girls and women?
Thank you so much. I'll actually maybe pass this on as well to Dr. Ayer, who is, because I have the unique role of being what you'd call a pracademic. So I'm somewhere in that space between practitioner and academic. So whilst I work in an academic environment, a lot of the work that we support is really more in the praxis, like working with entrepreneurs and health system policymakers to be able to then now bring evidence into action. But then just, building on my own experience, I think just the fact that, just demonstrating that there are multiple pathways to be able to get into the research arena. And there are multiple ways around which research can be done. Whilst I think a huge barrier has been that it's very hierarchical, academia is very hierarchical, and it can, of course, that pathway often has a lot of barriers, especially against women. And I think, other panelists will speak to that. I think just being able to demonstrate that there are multiple ways in which, you can have research, that it doesn't have just to be strictly in the academy, but then you can have, practitioners, whether they are nonprofits that are, as Dr. Gojoy mentioned, whether it is innovators that are coming through with, evidence on new interventions. So being able to see how to, broaden what the frame of research is, being able to be creative around how that's packaged. And that, I think, provides the narrative that there are multiple ways in which women can engage in this evidence collation and evidence amplification. But then I would love to have others who are more in the true researcher hat respond to that question as well.
Thank you, Dr. Odero. Dr. Iyer, would you like to tell us your point of view?
In fact, it's a very important question, and we have been working on localizing SDGs in India for the last 2.5, 3 years, where we go right till the grassroots villages to kind of generate data. And the biggest lesson we learned as part of our SDGs work is that we cannot, if we want to enhance women's participation or girls' participation, we need to take a gendered approach once again over there. And the reason is as follows. The politics or the gender relations at the village level determine who is going to be able to access what types of information, right? So here we find what we have started is a community knowledge approach, knowledge leaders approach, where we see the community as a source of information generation. And here you find girls playing a very, very important role in generating knowledge on sensitive issues, which are otherwise not spoken on public forums. And they generate that data sets, and we have, last year we had 450 interns, of which 300 were girls who were part of this data generation process. We taught them how do you really do scientific data work, and they've been writing good policy briefs, case studies, ethnographic work, that we could also not only do it in the general population regions. In India, we have this vast caste and class problem. We could also do this in tribal areas where the indigenous group girls participated extensively. Having said that, I think a more substantive approach is, and where India seems to have garnered its achievement, is in the last 15 years, ever since we started implementing universal elementary education through a program called Sarva Shiksha Abhiyan. Girls have started coming to primary schooling and schooling education. That's become universal. Okay, and over here you find that girls' participation and enrollment drive really scaled up significantly. At this juncture, you find them coming also to undergraduate programs. Enrollment has improved, I wouldn't say drastically, and that's where the entire education literacy drive seems to have brought in the cadre of youngsters who are willing to get into academic work or research. We also see them getting into civil society organizations willing to participate. Central to all of this, therefore, if we need anything, we need to trust our community knowledge. We need to see that the top-down approaches are actually debunked. It's not that everyone at the center knows it all. Trust the local knowledge. And also capacities of local universities need to get strengthened. And that's a bigger problem, Abhi. Most of the time, we have certain premier universities and institutions trying to steer knowledge creation. We do not want to transfer knowledge to the local bodies or local colleges that are present. And what we are doing in TISS is we are trying to work with local colleges and universities to do this kind of work. So there's research happening on both sides, dissertations, policy briefs written by them, and we are trying to steer the quality of their research there. So I think that's where academia should play a very important role if we really want girls to participate. Thank you.
Oh, thank you so much. I'm talking about that, girls and women are asset in communities. And in order to be able to really get to the bottom, the root of most of these issues, they are the one that we need to approach. And you'll be surprised, just a young girl who hawks, sells things, carries things all over and sells every day. She's full of wealth of information that when we need to know what's going on in that space, those are the people that we need to approach, to trust and be able to, use them as an asset, as a community asset. So thank you so much for covering that. I'd like to go back to Dr. Gogoy. The next question, this question is about what are your recommendations for action and policies to address the underlying health and economic inequalities? And what action must be taken by whom?
Thank you, Abby. I think I'll respond to the second part of the question. I think that if you want to change the world for women and girls, actions must be taken by everyone. So everybody has a part to play. I think it's really a fallacy to think that the government is suddenly going to, change everything and solve all the problems. It's improbable to think that the families have the resources to change the problem. So I think everybody has a role to play. But I do want to kind of make some specific recommendation and really building on what the previous speakers have spoken about. And I want to talk of, 3 elements first. I think as we are redesigning the recovery, we have to push that, number one, these plans are gender transformative. Sandhya talked about gender mainstreaming, but I think we really, really have to, push that it is not just people are not doing it just for the heck of it, or just paying lip service. So anything that is emerging, we have to question and deep and see whether it's gender transformative or not. The second thing is inclusive. I think COVID has also told us that while certain sections of society survived, it was very difficult for certain other parts of the society to survive. So I think the second recommendation that I have is to really be inclusive. And the third is intersectional approaches. I think in many of our countries, health is run by the Ministry of Health, education of girls is run by education. There are other people looking at gender-based violence, but there has to be intersectional approaches, if we really want to make life better for women and girls. And I think, it's a recommendations, it's many, enhancing rural urban employment options, educating girls, skill building initiatives, empowering women leaders that we have at the grassroots. Many in India, for example, local governance, you have women who are elected. In certain states, 50% of the seats are reserved for women. And these are women from the community. We really need to kind of, work with them, mentor them, to talk about what we have been talking right now. How do you get women at the center of everything? Frontline workers, what can we do for them? Because they are mostly women. And then, of course, I've already spoken about, equipping women and girls with 21st century skills. But I think, we have to now kind of disaggregate some of the large level recommendations and really figure out what works at that particular kind of context, culture, situation, country, economic class. And I think, we really have to focus now on ensuring that we are meeting the economic needs of women. So whether it is vocational training, skill building programs, but most importantly, creating pathways for women to join the workforce. I think as jobs are now opening up after COVID, the good jobs are being taken by men, because women, as others have said, you stay at home, you have a increased care burden, you take care of my old parents or our children. So I think, how do we create pathways for women to join the workforce? Because we know that if we help women to seek out independent livelihoods, attain financial self-sufficiency, they are going to make better decisions, not just for themselves, but also for the families and communities. The other recommendation that I want to make is, I had already spoken about it in my opening comments, but I think COVID has taught us that we have to designate some of the services for women, whether it's health or whether it's gender, responding to gender-based violence. These services must be kind of, categorized as essential. During COVID, all of us heard about, gender violence going up, families, locked in at home, you have lost your livelihood, so you're frustrated, so you're beating up, the women in your families. You're not getting alcohol. we had girls telling us that because there is no alcohol, there's violence in the family. And then when finally alcohol shops opened up, again, there was violence in the family. So I think we need to kind of ensure that, women, some of these services, whether it is, like I said, a helpline for violence, one-stop centers, counseling, family planning, childbirth, all of these need to be classified as essential services so that they are not disrupted during pandemics or such such difficult times. The other recommendation that I want to make is that we all know that educating girls really gives us multiple dividends. Educated girls marry late, have less children, they earn, they add to the families and the country's economy. So I think we have to look at girls' education, including kind of addressing the digital divide that I had spoken about. So even in the digital world, we need more gender responsive approaches, whether it is to remote learning, whether we kind of do girls, even if they have phone, they don't have internet connection, right? So how do we bring some of these internet connectivity devices to the last mile so that girls can use these assets in order to kind of make the best of their lives? The last recommendation that I want to really make is that I think mental health is, again, there is only, even in the community of people like us, we have a particular community who's working on talking about mental health. Somebody's talking about sexual health. Somebody's talking about economic empowerment. But I think we really need to come together and figure out how do we respond to the mental health need, which was always there, but COVID told us that we really need to create more awareness about mental health. We need to challenge the stigmas around it. We need to kind of launch campaigns about telling women and girls where can they get mental health support. And at the end, Dr. Iyer spoke about mainstreaming gender issues, but I also want to take it further and say that women and girls must be consulted, and they must be engaged in the decision-making processes, whether it's at the global level, regional level, national or local level. Because what we need to do is that we need to ensure that their lived experiences, women's lived experiences, are really meaningfully addressed. And I think a lot of us can also see the COVID response, response and recovery pathway as an opportunity to bring back things that we had, kind of fallen in the cracks. Yeah. I'll stop there.
Yeah, thank you so much. You covered a lot as well. There's someone on chat. She said quality, formal and informal education on gender-based rights and empowerment of women is a key factor to gender enlightenment. And I really like the way you said women and girls, they have to be part of the conversation. And the issue now is how do we create a space, a conducive space for girls and women to be part of the conversation? Because we know that it's men that run everything. And with the last, girls and women are the last to even, participate in any of the things that needs to be done about themselves, about them. So how do we now enlighten and educate the society to be able to allow women to be part of the conversation? Because there's a lot of barrier regarding that. It's easy to say, but in a practical way, is this something that is doable? That's the question. Let me quickly go to Ms. Ngogo. I'd like you to tell me what action should pharmaceutical industry take to address these challenges we've been talking about?
Yes, and I think again, I think broaden it. I think not only the pharma industry. I think it's I'll say it's really industry in general. It's sometimes what we call the private sector. I think for me, it's I see three words that are coming on my mind. It's coordination, impact measurement, and sustainability. And I'll start with coordination. I think that first of all, the government cannot do it alone. So we need to bring in partners. And then, so the private sector, including pharma or medtech, can be part of those, the efforts. In addition to that, there's some work that has been done in the past. And then we have to stop reinventing the wheel. We have to leverage on what has been done before and really take out those best practices and really use them. The second thing I mentioned is really impact measurement. And really here I'm thinking that, a lot of work is being done everywhere by many, many partners. And I think sometimes it's very difficult to see, what has been successful, what wasn't successful. So we want to make sure that whatever initiative or efforts are put in place, the right metrics are determined at the beginning of the project. And these can also help, to measure if it was actually successful. So making sure that we really create true impact. Yeah. And then thirdly, I really think sustainability is key, because a lot of the time, you might start with a foundation that gives money or a company that invests, and then sometimes they have to pull away. So we have to work with the government as a private sector. We have to work with other partners. We have to work with the local, really build local capacity, so that we can pass the baton and leave and make sure that whatever we've created is sustainable when we leave. Yes, and these could be initiatives, to empower girls, to bring girls back in the workforce, or even just initiatives, to help with health system strengthening. So yes, so I think those are, for me, 3 very important issues that we should tackle.
Yeah, that's very, very important, especially sustainability. We have I think we only have 4 more minutes before the end. I would like to ask everyone on the panel, if you must pick a priority, just one, if you must pick a priority, what would it be? I'll start with Dr. Odero.
Well, that's a hard one. I think it would definitely be, just making the case for a system-wide reforms that basically look at the intersectorality of the challenges and issues facing women's health. And so therefore being able to look at how adjacent sectors can leverage innovation to be able to change how, women's health is provided, and how women's health is financed, and the prioritization given to women's health issues.
Thank you, Dr. Odero. Dr. Aya, what will you pick as a priority action?
I would do a bit of a back jump there. I would try to say that let's recognize that we are in an interconnected, globalized world, and even national policies are being determined by global processes. So the thing that I would pick up is trying to look at how global policy making can be made more coherent in terms of gender mainstreaming and gender responsive, because what COVID-19 has demonstrated is we've used a very gender neutral lens to even recognizing that COVID is impacting women and men differently. And the multilateral institutions have not really emphasized the need to have more specific approaches for men and women. And that has seen very clearly leading to issues of not just the pandemic exacerbating itself the way it is, but also a recovery pathway is gender neutral. So I would like to place the lens right at the top, because that's where the problem starts, and how national governments are not responding effectively well, leaving it all to local governments to implement. So I would take the burden to the top there.
Okay, thank you. Dr. Gogoi, what would be your pick?
So Sandhya talked about taking the burden to the top. I will talk about taking the power to the bottom, in a manner of speaking. Often we say that women do not have the power to speak. And I just want to take a second to talk about the What Women Want campaign, which we began in India. And today it's a global campaign. What we did was we just gave postcards to women to say, tell us what you want. Right. And women told us, like, for example, they don't want to be abused when they go for services. They want, if government has said that these are your entitlements, they want to get those entitlements. And the What Women Want campaign, as of today, we have collected the wants of 1.2 million women from over 115 countries. There is a dashboard which is available in the public domain where you can, drop down, check the country, check the topic, and look at what women are wanting. So my recommendation is that we really kind of walk the talk and ensure that we are including women. Thank you.
Thank you very much. And Ms. Ngogo, I don't know if you want to add to this, because you gave us 3 very
I think for me, just an issue, I think especially that has been exacerbated with COVID is really mental health. I think, we need to destigmatize mental health. I think a lot of women are facing mental health problems. And I think also the youth. I think a lot of people think the youth is okay, but I think a lot of youth is asking themselves, what are they going to do? Are they going to survive after COVID? How are they going to earn a living in 5-6 years? So I really think that we really need to focus on mental health as a very, very pressing issue.
I do support that as well, because what COVID's done is really brought out how fragile our health and our body is. And thank you. I think this has to be the end, because I think I'm a few minutes past the time. And thank you so much, everyone. We've got a fantastic panelist, and we talked about the impact of COVID, the challenges and the opportunities of response, and how resilient women are. And so the bottom line is, we know that we have all of these challenges, and it's a multifactorial issue, but there is hope. There is hope, and there's a lot of work to be done, especially by we women, to be able to share, what's going on through our different professions and whatever we do. Thank you, Dr. Odero, for being just an excellent keynote speaker. Thank you, Dr. Ayer, for the work you do. And Dr. Gojoy, thank you so much for your work as well. And Ms. Ngogo, thank you so much for what you've shared, and it's been really enlightening. Thank you. And this will be the end of the